Thank you so much, Joe, and thank you for all of you for attending this training. Today, really, we will, I hope that it's a start of a conversation. I will give you an overview of the topic, but I hope that we'll continue these discussions and that this will be ongoing. Next slide, please. My slide is not moving, Joe.
Oh, click on,
yes.
There you go.
I didn't know. So thank you so much. Okay. So before I start this conversation, our first glitch, hopefully that's it. I want to actually acknowledge the community that produced this work. The kind of information and knowledge I'm sharing today is not one that's produced by individual, but really by a community of practitioners and partners. I worked for many years at Children's Hospital Boston, Center for Refugee Trauma and Resilience Center, where this work was produced. I worked with Dr. Ellis, Dr. Sachs, Dr. Molly Benson. This work was funded and promoted and held for many years by the National Child Traumatic Stress Network and SAMHSA. So they really are key to the production of what I will share with you, the knowledge I'll share today. Naima Agalab and Refugee and Immigrant Assistance Center in Boston, which is a center that serves the community that I've worked with since the beginning of this work. And then our community partners that have implemented this model and continue to work with us and continue to contribute to this development. In Minnesota, we work with a water course counseling center, the Center for Resilience and Social Development in Canada, in Ottawa, and also in Edmonton. It's Burnwick Services in Maine, ALV, and Connecting Cultures. We are about to put in this school, so these are our partners, and also all the community members, all the school partners, all the who contributed to this work. I just want to thank all of them and acknowledge them here. For today, I hope to actually do a 40-minute presentation or 45, and then we'll have 10 to 15 minutes for discussion. But the first thing we'll talk about is who is a refugee, because we keep talking about refugees, but what does that mean? How are they different than immigrants? And also, what are the unique experiences that refugees bring here when they come here as refugees? What are barriers to mental health services? What are core stressors? And this is a concept I will talk about because it's a model or approach or a lens that we had developed in TST-R. And then I will just talk about trauma systems therapy for refugees, a model that is empirically supported to actually effectively engage refugees into mental health services and to impact outcomes for children and families. Before we start talking about the topics that I just laid out, I want you to think about a young refugee child, a 13-year-old boy, recently arrived refugee from Somalia. Because of his age, he was placed in the 7th grade, though he never had any schooling prior to coming here. Teachers are really struggling with him in the class, saying that he's disruptive, he doesn't do his schoolwork. He is actually involved in the criminal justice system for activities like shoplifting, for fighting, for hitting people. There's a case open with child protection. His parents feel overwhelmed. They say, like, why is this child, after all we have done to bring him here, why is he behaving this way? And also they're overwhelmed by the constant calls and contact from system providers who are trying to help Abdi. Often Abdi, the family dynamic has become where Abdi gets blamed for all the bad things that happen, and he and his family are having constant conflicts. Because the family still has a lot of contact and elders in the Somali community in Africa, they have been actually calling to talk about how they are struggling. And the advice given is to send him back to Africa because he's changing so much. He's no longer behaving like what's expected of a Somali child. The family has been, the school and providers have offered to that the child needs mental health services, but they have refused. They're saying that, no, this is just a child who is being bad and that he needs to change his behavior. As we talk about this just keep Abdi in your mind. How will you work with Abdi? What system, what can we do to support Abdi and his family? So as I said, Abdi and others are refugees. So what does it mean to be a refugee? The refugee, the term is actually a legal status, and it is given by the United Nations. A refugee is a person who is outside his or her country of nationality, habitual residence, has a well-founded fear of persecution because of his or her race, religion, nationality, membership in particular social group, political opinion, and is unable or unwilling to avail himself or herself of the protection of that country or to return there for fear of persecution. So by the nature of the way that this status is granted, a refugee is someone who has experienced trauma, who has been actually expelled or displaced from their native the country of origin and cannot go back for fear that they will be harmed. So there is embedded in the granting of this status is a trauma. So then what is the difference between, say, when we talk about immigrants versus refugees? What it really depends what we're talking about. There is obviously a difference in legal status. So a refugee is once they come here, they are already coming here documented and with legal status to be here. Immigrants may do the same and come with a green card, or they may be undocumented, as we see with young people arriving in our southern border. So that is more or less a label. What is the status granted? But there is a huge similarity in experiences. So a refugee gets that status because of this inability to return to their place of origin. Often, you know, the young people we see who come from the Northern Triangle, from El Salvador, Honduras, Guatemala, actually have similar experiences. They can't return either. So it's often a political status given because of politics more than it's really that, you know, the refugees have more trauma. Refugees have huge trauma and loss, but so do others who come to this country that don't get the same status. So there is a difference in the status. There is a difference in access to services. You know, things are constantly changing now, but traditional refugees had a very good access to services. So they could get public housing, they could get benefits and so on, which may not be available to immigrants regardless of their status. The other thing is that there are other groups, unaccompanied minors, asylum seekers, temporary protected status recipients who actually also are like refugees, it's simply that they have a different status that also confers different rights and responsibilities. When we think about the trauma that refugees have been exposed to, we actually think of it as pre-migration, during migration, and after migration. Often refugees, before migrating from their place of birth, they may have seen death of loved ones, torture, imprisonment. I will tell you, like, I am a refugee, my family is refugees, and I have all of this in my family history as a refugee. During migration, people have to travel long way to get to a place of safety. Think about that. To be a refugee requires that you are in a second country. You cannot be in your country of origin. You cannot be in the country of asylum to actually apply for a refugee status. So if you're Somali, you have to be in Kenya or Ethiopia or other countries to get that status. Many of the Somalis that I know had to walk for months to get to Kenya, for example, on foot, being hunted down with no food. Many of the families I work with have lost children during that migration. So there is a lot of trauma during migration. And then we think, you know, and actually refugees believe once I arrive in the US, I'm going to be safe. My life is going to be, actually, some of my clients told me, I assume once I get to America, I'll get a big house, a big car, because that's all they see like on TV about America. But the reality is the kids that we have talked to, the kids that are in my research in our programs, they actually endorse more exposure to trauma here in the US than they do in Africa, in war zones. And so Somali kids endorse more trauma here in the neighborhoods, in places like Boston and Maine and Minnesota and Canada, in Toronto and Ottawa and Edmonton, than they've seen while they were in Africa. And what that tells us is actually for many of you, if you're working with non-immigrant kids of color, kids from communities that are resource limited, those kids are actually experiencing the same experience or even worse than refugee kids. And so being trauma informed, being knowledgeable about trauma and how to engage and how to provide services around trauma is on all of us, regardless of the population we work with. Refugees bring other unique experiences like cultural and linguistic that we also have to pay attention. So one way to think about how do we organize, conceptualize, what are the stressors that refugee and immigrant youth face and families face when they are living here, when they come here after they arrive here, youth like Abdi and his family, is to think about what we call core stressors. So this is a tool, it's an assessment tool, allows you to assess the needs of a family or a child, and also to plan treatment. And what the core stressors are, we know already, I talked about this, that there is trauma history, so which impacts emotion regulation, social support, the whole environment. But we also have to keep an eye on acculturation. What's happening to family relationships? What's happening to language learning, cultural learning? All of those also impact the family and the child. To think about isolation, and especially right now, to think about discrimination, loneliness, alienation, what are the social support and social connections that are available to the child and the family? And also to really prioritize and keep your eye on what we call resettlement stressors. Often families will come to me and say, someone will come to me and say, Saida, you know, I can't sleep, I'm depressed, I'm not depressed, okay, so not depressed, but I'm sad, and I'm always crying, but I don't have housing, or my housing is in danger of being lost. If you help me with this, I will be fine. And if I don't say, okay, I'm gonna help you with your housing, then I'm not really, like, I'm not, families and communities will not see me as someone who is helpful, because this is what is their priority at that moment. So we need to keep our eye on what are resettlement issues of everyday life, like basic needs, finance, healthcare, and legal, that are stressing like families like Abdi's. To just give you an idea of what is happening with, we already said that refugee children and their families and their communities have had trauma exposure, both in Africa or wherever they came from, Asia, Africa, Europe, wherever that family came from. The idea that you have been expelled, that you have been dislocated and you can't go back has this trauma embedded. And actually research shows that there is a higher exposure to trauma and higher symptoms among this population. But then what's happening with service provision? Are those kids and families seeking mental health support? And this is from research in New England with Somali youth and their caregivers, where 1/3 of the young people, these are teenagers, adolescents, 1/3 of them, so about 30%, 33% met the criteria for PTSD, but only 8% were receiving services. So there is a high level of exposure, high level of need, but very limited utilization. And today's discussion is really, how do we think about models of care, interventions, practices at both individual clinicians level, at the institutional levels, that enhance access, that improve engagements? How do we identify barriers to engagement? So if 92% of those young people who need mental health are not coming to our offices, we can't just keep sitting in our offices and waiting for them to show up. We need to examine how we do things, and we need to change how we do things. I always say, because I've worked so long in Boston thinking about this issue of health access, that you can't just sit and say we built it and they will come. Boston has some of the best healthcare institutions. It also has Massachusetts has what's as close to universal healthcare as you can get. We are still not reaching these populations. And so it's time to ask ourselves, not why are they not coming, but what do we need to do differently to engage those populations that we are not reaching? And today more than ever, because of what's happening with COVID. So what are the barriers that we have identified with refugees? And this is again from the work that I've done with the Refugee Trauma Resilience Center at Boston Children's Hospital, and the team with Dr. Ellis and her team. And the first one is actually distrust of systems of care. And partly this is because the communities we're serving don't see themselves in those systems of care. They don't see their culture, their experiences, their faces when they arrive. And there is a long history of distrust. Often also refugees come from places where systems where what get them expelled, what get them displaced, the violence that displaced them from their home is often violence engaged in by institutions. So big institutions, when you go there and tell them sign something, there is a distrust, there is a fear that we need to work towards removing. Then the stigma, there is a shame and stigma attached to mental illness. Also because many of our refugee communities come from places where there is no medical interventions for mental illness. So people feel like if someone has a psychological distress, they will never, quote unquote, be normal. Language and cultural barriers, I don't have to say much about this. Those are huge and we need to address them. But then what I just talked about before, primacy of resettlement stressors. People are trying to build their life here. And the idea of going to a therapist and paying and sort of going weekly to a therapist and talking to someone often is not on the top of the list of things they need to do. What is the consequence if we have those young people who are in need of mental health support? We need not only just mental health support, but actually we need to address trauma. Is a unique trauma impact or trauma effect, PTSD, is a unique kind of psychological distress because it impacts the sense of safety, the sense of competence, the sense of trust, all the things that we need for young people to succeed. What is the cost? Well, there is a social cost. There's an increased risk for interpersonal difficulties and drug abuse and isolation among young people if we do not address trauma and trauma effect. There is a psychological cost of consequence, an increased risk for mental illness. There's academic, an increased risk for learning problems, low academic motivation, and low school failure, and school failure. What this means is that we need to address this now, we need to address it early, we need to address it effectively, because otherwise the price we pay is not just children, we're actually going to lose children. We're going to have families that are fractured and in pain. And the ultimate thing is we're going to have communities and society that will have young people who are not able to achieve the potential, their potential. So this is something we have to do something about. So now let me talk about the model I will present, which was essentially created with an attention to that idea of how do we engage refugee communities and refugee youth and children and families to service. What does a model that's effective look like? Trauma systems therapy for refugees is an adaptation of trauma systems therapy, which is a widely used intervention. And it's first a clinical model for the efficient and effective treatment of traumatized refugee children. And TST is for all children, but the TST-R is for refugee children. But it's also an organizational model for the integration of services for agencies to provide treatment for traumatized refugee children. So it is actually leading us towards the idea of the institutional structure, the way we organize services, the way we serve those children has to also be examined. And the first thing we do when a partner says they want to adopt TST-R is actually meet with them and work on organizational readiness. Do you have everything in place that you need to do this well? So that it's really important to keep an eye on that organizational aspect, because we can't just expect children and families to change, we need to change as well. But TST-R, the R part, is also this idea of paying attention to the culture and experiences of the communities we serve. So saying, you know, we have all those models, all these interventions, but it can be the most perfect intervention if we haven't accounted for the experience, the culture, the values, the beliefs of the communities, of all the communities, but specifically in this case for refugee communities, for cultural communities, for minority communities, then that model is useless to me. And if we cannot engage, if we have not done the work of engagement, partnering, acceptancy, then if no one is going to adhere to the treatment, accept services, again, the model can be perfect, but it's no use to me. Trauma systems therapy for refugees takes a social ecological approach to work with refugee children and families. We think about children, yes, the child, Abdi, the young person I talked about before, that child is experiencing psychological distress and is having difficulties in school, at home, in the community. But in reality, trauma impacts not only a child, it impacts a family, a community, peer groups. So we want to say that the work we do, the healing we're doing addresses not only the child's symptoms, but the family, the school, the peer, the neighborhood. So both risk and resilience lie in the social ecology, and we have to address them both in the social ecology. So while we're going to do help the child individually self-regulate, learn coping skills, we're also going to work on the social environment to make sure that there is a resilience within the social environment that is strong enough and healthy enough to support the child. So what does that mean? How does it work? At the first part, in the first part, TST-R is about a social intervention. So it enhances the capacity of the child's social environment to protect the child from current threats and traumatic reminders. So there are two ways that trauma impacts are. There is, think about trauma as if you were someone had been harmed by fire, and then now they have they experience that traumatic event. So there's two ways. One is to remove the reminders of that trauma. So if someone is re-experiencing the trauma because there are things like violence in the community that are reminding them in the home. So in one way is actually to remove the reminders, but the other way is actually to make sure that that trauma is not happening again. So if a child was abused, the first job is to remove the abuse. And then the second is to make sure to help the child and the social environment to heal from the abuse that had happened. So it is both to protect the child from current threats, so like Abdi, to protect Abdi from current threats, but also make sure that there are things in the social environment that remind him of trauma that has happened in the past, that we are cleaning the social environment as much as we can, and then supporting the child's in that process, supporting the child's regulation. So the social environmental intervention, but child-focused as well. So simply really enhancing the child's capacity to self-regulate. Because no matter how hard we work, we can't remove every reminder. So we wanted the child to build those skills to self-regulate. The most important thing about also this work is that there is a partnership between culture and clinical and cultural partnership, that we use teams composed of cultural brokers and clinicians to support the child and caregivers. And caregivers include teachers, social workers, all the people who actually come in contact with that child. So the way that TST-R services are structured is actually we try to walk the walk by starting with community-wide psychoeducation. So we build relationships, capacity. So we call this tier one. It's a public health model where you are doing, first you're actually reaching as wide as possible the community. And I will show you our project in Canada and how that works. But tier one is, we will take at least a year or 6 months to actually do community-wide education, relationship building, working with community leaders, opinion leaders, people who we know, if we partner with community members already trust. So what we're doing is, if you want to reduce stigma, one of the things that you can do is actually build the community's capacity to accept these services as something that is not less than, that a person who needs these services is not less than, that they can actually succeed, that they can achieve life goals, that this is something you can come back from. And partially, of course, in that also what we're doing is using language and culture, and I'll talk about this later, that is acceptable. I talk about trauma with you. If I am talking to refugee populations I'm working with, I will never talk about trauma because there's not even a word for it in my language. I will talk about things happening that hurt. I will talk about if car hits you, it hurts your leg, and you may actually need a doctor, and it will, hopefully the doctor will do a good job and then you will be able to walk, but you may still feel some pain. And I think I talk about how in your heart, in your soul, sometimes when bad things happen, the same thing happens, that it can cause a lot of pain and you need help. But then just like if your leg is healed, you can get up and walk later and go on with your life. You can do the same. I also talk about how if someone was hit by a car, we don't actually tell them, get up, why are you sitting there, go, No, we go and we supported them and we help them and we make sure that they get the care they need. We should be thinking the same way about people who have had a trauma or other psychological issues, because what we're saying is it's okay. It is something hitting your soul or your heart, depending on what language you're using. And so we use everything that I'm presenting today. I'm using TST-R language that I will use when I present it to practitioners. But if I'm doing this for community, then I will be using a language that aligns with community values, understanding language. Does not sound like I have no idea what you're talking about. Tier 2, so tier 1 is that work with the community. Tier 2 is skill-based groups, again, not to reduce stigma and also to build trust. We usually place these in the schools, but it can be done in the community. There are manuals. We have I think now we're going towards 9 or 10 manuals. They're adapted for specific groups. Adaptations are done by community and clinician, so community members and clinicians, so that we are actually embedding community values and ways of seeing. For those of you who work with Latinx community, there's actually a Spanish one that is being piloted by Children's Hospital right now. So, and then there is a Bhutanese one, there's a multicultural one, so we have many of them different. Myself and another colleague created the original one. This is a long time ago, but now it has really evolved to multiple cultures and communities that we're constantly adapting to make sure that we are actually speaking to communities. But what these groups do is they build relationships, they provide a space for kids, young people to find role models, to find support, to learn pro-social behaviors. And while also they are engaging with clinicians and cultural brokers who can then help and support those young people if they need a higher level of care. So it's both to engage people, to engage families, youth, to build some skills, but also with an eye of identification of young people who are in need and helping them to, if they need a higher level of care, getting them that service. Tier 3 is essentially what you will normally have in a clinical office. So there is some cultural support, but it's not as much as the other. And we call this regulation focus because what you're really focusing here is a child who the social environment is stable, but the child is dysregulated. So you're helping the child to regulate, to learn those skills. Tier 4, on the other hand, is safety focused. It's essentially often a child who may not be able to self-regulate in a social environment that is not able to support that child. And so this is, we call it safety focus, because in reality, what we are paying attention to here is creating a more stable, more safe, more caring, more capable social environment, because there is absolutely, to me, it is absolutely criminal to ask children to do work that we are not willing to do as adults. So asking children to self-regulate when they are faced by threats and they are being reminded constantly of trauma is not fair. So we need to clean up the social environment, build those resources so that children then can, in a safe and caring space, learn those skills. Across all those tiers, we have cultural brokering. And a cultural broker is someone from the community who knows the community's cultural values, beliefs, but also knows healthcare, mental health care, primary care, whatever the field they're going to work in. And what happens is they are actually a bridge between the community and the practitioners or the clinicians. And your job is not just to support the community, to learn about what we do and how we do it, and to give the knowledge they need for children to heal. their job is also to support the systems to change. So they're as much there to help the clinicians learn how to provide better service as they are to support families access that service. And it's that mutual change that is important. We are not expecting families to change, we're expecting clinicians and providers to also change. What are the objectives of TST-R? Well, the first one, as I talked about, is really to engage refugee children and families in service, decrease the stigma of mental health, increase identification of refugee children with mental health needs, and not, and psychosocial support needs. I mean, we really want to get to kids long before they are in crisis like Abdi, right? So that's what the group is do. That's what this building a relationship with the community, with religious leaders do, is to help us identify young people who need help long before they get to the point to where they're in crisis. And we also work with the community, with as well as with schools, to actually provide sustainable, culturally and linguistically appropriate school-based mental health services. And this is so important. I am so proud that many of the places where we have done actually TST-R, there are now community-led clinics that are providing services in mental health, embedded in concrete services, which I'll talk about a little bit later. But I'm so proud that we have not left any place without actually an improved mental health service available to those communities. And just to reduce core stressors in the child's and adolescent's social environment. So to essentially clean up the environment, because a child like Abdi, who is, as I said, experiencing triggers and pain across the social ecology, for us to sit and wait for him to change his behavior is not realistic. Also, we take a cultural humility stance in this work. For me, this is really important. I want you to know that I used to talk about cultural competence, and for a long time I used to say, really, like, especially when I was in Boston, I was training medical doctors and psychiatrists and people who were affiliated, because I was in the hospitals. I would say, I really don't want to tell these colleagues that they have competency, because what will happen is they will run with it. And then I discovered cultural humility. So while knowing about the culture of the communities you serve is really important, the first step is actually knowing yourself. So a commitment to self-evaluation and self-critique, identifying your own biases and assumptions and addressing them and how they impact the way you provide service is really important. Recognizing and acknowledging and changing power imbalances between ourselves and our communities that we work with. And this is really important. The last one is actually commitment to social justice and institutional transformation, but constantly working towards rebalancing those relationships. That we cannot continue doing the same thing and reproducing disparities, that we are each responsible, holding our institutions accountable to change, is really important. On developing mutually beneficial partnerships with communities and working towards institutional accountability. So for me, cultural humility is a core. So let's go back to Abdi and Abdi's story. And I want to just go through like what will happen with Abdi if actually we were using the TST-R lens, and specifically we're using the Core Stressor as an assessment tool. So we will first identify, the first thing we'll say is there a history of trauma? And we know there is. He came from a refugee camp. There's actually a community trauma where he's at now. And there's the trauma of education, being placed in 7th grade when you have never been to school. That itself can be traumatic. And we also see there are triggers in the social environment, including how the teachers are reacting to his behavior. There is he's being punished, and also the family conflict. We also see there's a huge acculturation stress, including his interface and interaction, or his being exploited by youth. This is like behavioral learning, the culture of the communities or place where you live, when the parents don't even understand what that is. He's struggling with learning a language. There's a family conflict because of the change in Abdi's behavior, and the parents are parenting a child in Africa when in reality, they don't understand what's happening in the streets when Abdi is outside. I do training for parents, and the first thing I say to them is, do you know what happens when your child leaves your door and is trying to get to school in this neighborhood? And often they don't. They think if a child has a breakfast, a pen, and a book, they should be going to Harvard. And the reality of children of color in neighborhoods where there's a lot of violence and there's school failures and so on, that's not a reality for the children. We have isolation, bullying, and discrimination. We have resettlement stressors. So we will take that lens to identify, and what we will also say is, what is driving the behavior? What are the things we need to address right now? What are things we can do right now to make the family and Abdi's life better, to improve, to create a space for Abdi to learn self-regulation and coping skills, and to be able to function in the school in a safe way. So we will actually put Abdi, we have a whole grid. I do not share the tools today because this is more an overview and not training for practitioners who are going to practice this model, but we have, in the safety focused tier 4, that's where we will put this family, and we will actually provide home-based services. We'll provide a cultural broker who works with the parents, helps them navigate the systems, but also works with the providers and helps them understand Abdi's experience, and works with the school and teachers and helps them. I do a lot of training for teachers, and they always say to me, if I had this training before when those kids came to me, my experience with them would have been completely different. And I want to give shout out to all the schools we worked, including schools in Minnesota, in Ottawa, in Edmonton, because they, every time, and now I'm starting with Burlington, Vermont, those schools and administrators have to step up and provide a space and engage with us, and it's a lot of work to launch this, but they're also champions for change, and they want to see something different for those children, and I thank all of them, and I'm always grateful. So we will also put Abdi in the groups because this will help him engage in pro-social activities. It will build his self-regulation and coping skills. It will also help him to engage with clinicians and community members or cultural brokers who then can help him get into a more higher level of care, because you need that stigma reduction and also trust building, both of which are provided by the groups. We will provide consultation. The cultural broker and TST-R team will actually provide consultation to the systems of care, including the school, DCF, all those who are interfacing with them, to understand these families' experience and needs, and to provide them with cultural and linguistic support. And then we will support the family with referral to community resources. If you don't do housing, know someone who does. If you don't do, courts, whatever you don't do, if you're going to, especially for clinicians in school, social workers, if you're working with these communities, with refugee kids, and I know you all know this, I think one of the big things about TST-R is how do we link those services so we are all working together. But the resettlement stressor is so core, especially for people who have had such a lack of resource for a long time, that we have to have answers to the question is, what about my housing? What about my job? What about, this legal? And it's kids like Abdi who have court case, it's constant stress on the family. So how do we get the mentors? How do we get them support for the family? I have engaged with youth, African-American youth advocacy programs that work with African-American youth who are engaged with the criminal, who are involved in the criminal justice system, who advocate for them. I've worked with universities to provide mentoring for refugee youth. It's always building that core. You can't do everything, but you have to know people who do everything. So I just, for the final, I'm so sorry. Yeah, we have time. I want to just show the last two slides. One is this one I wanted to share, and thank you for the Recho team. Many of them, Recho is our partner in Canada, Edmonton and Ottawa, a huge project that I have been the PI for. And what we're doing is actually implementing TST-R with Somali young people, middle and high school. It's a very well-funded project funded by the Canadian government to see impact that this kind of intervention can have on young Somali Canadian youth. And what we have done is partner with these schools, again, very grateful with those school boards, and we are now providing services in the schools and in the community. And there's a whole team, including cultural brokers, youth workers who are also cultural brokers, clinicians who are all doing this work, hard work. And I have never been more grateful to partner with young people from our community. Many of them are Somali and refugees, so young refugee and refugee youth who are giving back to their communities. What I want to show you is that the first about the engagement, about doing tier 1, tier 2, tier 3, and how it works and how you build the momentum as you build the trust and reduce stigma and you bring resources to the community. Our first year was sort of a wash because we lost 6 months because of the way the grant was set up. So we didn't actually do as much work as we would have liked. So I'm going to get to the second year. As you can see, we said we're going to do tier 1, which is the community education, psychoeducation, outreach. We reached that. And that's always, for those of us who have been in the community for a long time, it's a much easier work for us to do. Tier 2, which is the group work, we said we will have about 80 to 150 youth. We didn't reach our goal because we were still building that trust and we were still reducing stigma. And then even less with tier 3 and tier 4, which require consent, greater consent, because those are, you have to give a diagnosis and so on. So we were doing some work in the community, but we were not reaching the goals we would have liked. If you look at year 3, after we've been there for a year and a half, we built those relationships with the community. You can see we're still doing very well in tier 1, which again, we continue doing those community education engagement work. But you can see our group work, I've never imagined we'll have so many groups. And these are all school-based groups and they're amazing. And so you can see we had over 100 youth participate in the group work and about 50. So we're achieving those goals, again, doing all that groundwork of building trust, providing reducing cultural accessibility, addressing other barriers, and so on. And thank you, Racha team, for sharing this with me. So I just want to say final words about the importance of community engagement in TST-R. Community engagement activities are really important because usually you learn about your communities and the engagement you're doing and the work you're doing with the community has to be harmonious with values of the community we serve. So we adopt a language and framings that are really integrate community beliefs and community desires. And so, for example, when I talk about children, I don't talk about the bad thing, like I don't talk about trauma. And I know, I say bad thing because for the community, for parents, this is another deficit. So I don't talk about deficit. I talk about goals and achievements. I start with the idea, I know you have high hopes for your child. I know you want them to do well. So like a young person like Abdi, I will not, I will not take parents back to a trauma so that they experience and then they really see me as the person who comes and talks about bad things. I take them to the future, to the hopes and dreams that they have for their child. And I say to them, I'm going to help your child achieve those goals. Community engagement activities also can increase an understanding of why. If people are not coming to us, why are they not coming? Or how do they think? I never start with clients is that, with a diagnosis or talk about. I actually start with learning about what they think is the issue. So what do you think your child has? But also more importantly, what is driving this behavior? More importantly, who do you usually go to for those kinds of things? What kind of support do they give you? Like, who do you trust? Why do you trust them? What is your expectation of this intervention? Because often, like with Somalis, even though I'm Somali, it's like, Saida, make this child a good child. And of course, that's not what a clinician does. So I have to discover with my clients and work towards a common understanding of what the issue is, what the things we're going to do about it are, and what the expectations are. So I just want to do that slide. I'll share it. Finally, I want to say this, that for any of you who work with diverse communities, I want to share this slide where with TST-R, we identified specific barriers and how we address them, because you can do that with any community. So distrust of authority within the community engagement, you saw that. Linguistic and cultural barriers, we partner with cultural experts. Providers partner with cultural experts. Stigma, we embed services in schools, in communities, and we work with communities. And we integrate resettlement, primacy of resettlement stressors. We actually integrate concrete services. I think I'm going to stop now. I have some readings that I will share with you. And then please go on the NCTSN products website. There are a lot of resources. Also, Boston Children's Hospital Center for Refugee Trauma and Resilience has that tool that I showed, the Core Stressor Tool. And if you want to talk to me or need more training or consultation, just email me. Thank you so much. I think we can start the discussions now.
Thank you, Dr. Abdi. Great presentation, and we have so many great questions. I'm going to jump right into it. Do you need a drink or a breath or a stretch?
No, I'm good. Let's do it.
Okay, I'll make sure you're comfortable. So Peggy sent me an email last week right after they registered. I don't believe they're with us today, but Peggy, thank you for the question. Peggy says, I'm so excited to attend this training and learn more about a model of therapy that works with immigrants and refugees who have experienced trauma. I have a question that's been on my mind for a long time. I've known mental health therapists who believe an immigrant or refugee could benefit from trauma therapies such as ART or EMDR, methods the therapist is trained and certified to use. However, I cannot find research indicating these models are effective for this population. What is your opinion of these models for immigrants and refugees?
Oh, this is such a hard question because I really don't want to respond to specific models, but I think I want to say what I said before. When I hear about a model for refugee and immigrant populations, my first question is, have they been adopted and have they been shown to be effective? Because no matter how good a model, the model is with the wider population, if we're not attending to those issues of culture and language, then it would be very challenging to work. So my answer to her is, I personally always look whether this has been adopted and there has been attention paid to the cultural, linguistic, and barriers that those communities face, unique barriers. I hope that answers.
Yes, thank you very much, and thank you for the question, Peggy. Anna asks early on, what is a cultural broker? Could you explain that more, please?
Yes, thank you so much. So cultural brokers, and I can share a slide. I will add a slide to the slides you will share so that it describes it. I had it, but I removed for time. A cultural broker is actually an expert in the cultural community you're working with, as well as the field. So there will be someone who knows about mental health, who actually understands the value of mental health, understands the barriers, all things we talked about. Often I say, of course, there are people from the community. They themselves have to be champions. They have to be people who understand the issue that you're talking about and are champions for the service you're trying to provide. They also have to be people who are respected. They're like gateway, we call them also gateway providers. They're the people who the community will see you through. So if I'm a cultural broker, the community will say, Anna, let's use her name, is the person that works with Saida. So they will see me. And so I have to be someone who has access, who is respected, who the community trusts, all of those things. What they do is bridge that relationship between the system and the community. I hope that answers. I will share 2 or 3 slides about cultural brokering because I get asked that question all the time.
Thank you, Saida. There are 2 questions here I'm going to kind of dovetail together. Christine asks, is the intervention available in a structured format, particularly tiers 2 and 3? And Ryan asks, shouldn't safety be in tier 1, not 4?
Okay, so Ryan, thank you. I will answer that question first because so the safety focus is actually more about whether, so we have a grid that you use, and the grid actually has 2 things. It has the social environment's capacity to keep the child safe and the child's capacity to self-regulate. And if a child is very much able to self-regulate, but the social environment is not safe, safety focus will be like, we need to make the social environment, if a child is not getting, parents are not able to help school, whoever is technical. So we need to clean up the social environment, the threats in the social environment. So that safety focused idea is actually where do we put our work in? And tier 1 is not, you don't have any clients in tier 1. Tier 1 is actually only community-wide education. So that's why it's not there. And the second question, this is available. We usually used to do this intervention in its completeness. So if you were doing tier 3, and you're a clinician, then we will actually provide training for you and support, because tier 3 is the least, it requires the least, how shall I say, resources, because it's essentially like traditional therapy, right? We have been doing tier 2 by itself now, so we can provide training for, say, schools to help them do tier 2, which is the groups in the school. But you still have to have available providers in tier 3 and tier 4. So if you have a child like Abdi in the school and you're doing groups and you identify that they need either individual therapy or they need tier 4 intervention when you're doing family therapy, home-based therapy, you have to have access and partnership with people who will provide. So yes, while we can provide these services separately, we still want to have a comprehensive available care.
Thank you, Saida. Dr. Antonia Apollinario Wilcoxon had a question. There's a marked decline in the numbers for tiers 3 and 4. Do you partner with psych treatment centers, and are immigrant refugee families utilizing them? Thank you.
Can you repeat that, please? Sorry. Can you repeat that?
Sure. Yeah. There is a marked decline in the numbers for tiers 3 and 4. Do you partner with psych treatment centers, and are immigrant refugee families utilizing them?
They are, and that's why I showed the Retro Project sort of numbers, because yes, early on when you start, you may have a lot of kids who can attend tier 2 because it's not stigmatizing, it's school-based or community-based. So we have those. And then you may have a lot of people who we reach through tier 1. But once you build that, you reduce stigma, you build that trust, you will have, we have had, we sometimes do presentations while we were in Boston, but now with Ratchet too, when we talk about people and community self-referring, and people like are shocked of that we had 100% participation of all the kids that were referred, because you have to do all that groundwork of trust, stigma reduction, providing other resources. But once that is solidly in place, we do have a lot of people utilize, and we have self-referrals from community members. We have religious community, both in Maine and in Massachusetts, where we did these services before. There are actually now community clinics, which are self-sustaining and providing mental health services.
Thank you, Saida. Let's see, an anonymous question that came in. Given that many clients who are refugees ask for an interpreter, what are some important things to keep in mind when there is a third person in the room? So
if you like, I can also share a few slides. So maybe when I send my slides, I'll add another one, the difference between an interpreter and cultural broker. I am, and I think my colleagues that I work closely with, we really want cultural brokers, because we find, I do training on interpreting, so I have a lot of knowledge around interpreting. We actually published through NCTSN, again, another shout out to NCTSN, we published a manual for interpreters, working with interpreters. So if anyone is, maybe I will send you the link, partnership between interpreters and clinicians specifically. So having a third person, it really affects the relationship, and it is so important that the clinician and the interpreter are prepared. We usually actually advise that they meet about 5 minutes at least before the encounter with the client and after to debrief. I will send you a link for the manual. The manual came out of a huge group of people from NCTSN affiliates who worked very hard to pull this together. So yes, it affects the relationship. There should be more training for clinicians on how to work and how to optimize the interpreters in the room, and to make sure that you're still building alliance and relationship with your client, even though we call it a triad instead of a dyad. And the triad, what happens is actually the interpreter has the most information. So we have a triad that we created that asks who has all the information, and it's the interpreter, not the client, or the two key people who are supposed to be in that room are the clinician and the client, but actually all power is with the interpreter. So we have to do a better job of training interpreters and also training clinicians and providers so they know how to effectively work with interpreters.
Thank you, Saida. We have time just for a couple more questions here, and then once we stop the recording, we're Dr. Abdi, sorry, has agreed to stick around for a little extended chat. So we'll have time to get to a few more questions. We have just a couple here left. Oh, Christina asks, I'm curious, how is Tier 4 different than a wraparound program?
It's different because of the cultural brokering. It's different because of that we use the core stressors to identify it. It is built around a similar concept, but it's a completely different because and yes, this will be families that will probably benefit from around the service. But the whole purpose of the intervention is around those cultural, to address those barriers to care, to engagement, right?
Sure, thank you. Thank you for expanding on that.
And just so she knows, can I just add something that
sure.
We did the first time when we piloted TST-R in Boston, we actually worked with the Home for Little Wanderers, which does provide service, wraparound services, again, bringing that part to the work that we have done. So yes, it's similar, but then the lens is different, and also the culture and experience part and partnership with communities is different.
Thank you for expanding on that, Saida. And finally, David asked, can you describe some strategies to engage Somali youth and families in the context of the intense stigma around mental health services?
I think, oh my God, that's such a big question because that's what I spend my whole life. I think that the language we use is really important, how we talk about mental health. It's very important that we provide more spaces to listen to the families. One core thing about Somali families, because I work with them, which is why I had the Abdi example, is often families and parents and older Somali community members see the issue through the lens of a behavior. So they will say, this child is behaving badly and we have to change their behavior. And so the really core thing is helping families and communities to understand what trauma is, or what mental psychological distress the child is experiencing is, but also to provide an answer, to provide a hope, to use a language that's hope building. So instead of talking about the deficit, talking about the hopes and dreams. I can provide more. I mean, we have a book out, so I won't go back to but the book that Dr. Heidi Ellis, myself, and Dr. Weiner wrote is actually available on Amazon, and it's going to be on also the PowerPoint, and that talks to how do we engage. So there's a lot of what I'm talking about today, but that should be a really good way to think about it. But I can also continue this conversation. It's just a big question, and it's so nuanced that I don't think I can just answer it in one go. But I think paying attention to the things we talked about today, what are the barriers, and also the framing, the language, the relationships, having cultural brokers and community people that you work with that can support you.
Thank you, Saida. Well, that is our time for today. On behalf of the Center for Practice Transformation, I'd like to thank you all for taking the time to join us for this wonderful presentation. And I'd like to extend an extra special thanks to the School of Social Work's very own Dr. Saida Abdi. Thank you, Saida, for sharing your knowledge, your research, and your wisdom with us.
I just want to say thank you so much, all of you, for taking this time, your lunch with me, and for just your seeking knowledge to support our families and communities. And just given where we are today with COVID, the work we're talking about has never been more important. Health disparities have never been more clear than they are today. And I think doing this work, not in crisis, but every day, hopefully will prevent another crisis where we see, how wide and deep those disparities are. So thank you for taking the time, and I hope that this is a conversation we continue, not a one-time thing. Thank you.